Can you remember how you felt when you got to a stage where you were seeing patients that you realised the reality of the PDoC diagnosis?
Yeah, I mean, you get to the point where you work through their acute care, so they come off the ventilator, they come out of the ITU setting and onto a neuro HDU setting. They've very often still got tracheostomies in, and the families are very focused on their acute care, that tracheostomy coming out, and the fact they hinge on, like, well, the tracheostomy is me, that's why they're not talking. So they are awake during the day, but we'll get that tracheostomy out and then they'll start talking to us. So you have to start very early with the families, discussing that, you know, it's not just about the tracheostomy, it's linked to their head injury. Their head injury is why the tracheostomy has been put in, and the tracheostomy is also linked to why they can't talk in the way that you'd be used to at the moment, but equally their brain injury is linked to why they're not making an attempt to talk with that trachea in. I think you just have to start very early with the family and introduce those concepts that the head injury is the overbearing issue, and that we can do everything else around that to improve their medical care and improve or sustain their condition. So sustain their positioning, sustain the length of their muscles, sustain their joint use. We can do all those other things, and we can guide any spontaneous recovery that's going to occur. But as far as actually changing their brain injury, our resources within that aren't capable of reaching those limits. And I think as you've seen more and more PDoC patients, you get to notice the very early signs of things that just don't quite add up. They aren't showing you the precursors to waking up. The patients aren't showing those precursors to having an awareness. Just very simple things like you're moving around the bed and the bedside falls down, and there's no movement, there's no turn to the stimuli, there's no recognition that something quite loud and upsetting is potentially going on around them. And I think the team starts to see those things building up as a picture. Nursing staff will report that they may have soiled their pad, but that's then not reflected in a increase in heart rate or blood pressure, and the patient shows no level of distress that's linked to that. So the team starts to become aware that even in the acute setting, we're not seeing those very early signs that this patient is going to make a degree of functional recovery. So it's all those little things that start to add up that is why it's so important, even in the early stages, that the team communicates and works together, and then that those messages can then be projected to the family in a cohesive way.